today's presentation. The outline of today's presentation is going to be on this wise. We are going to look at a brief introduction, and then we'll look at a brief history of enteric fever, and then we'll look at some of the causes and the etiological determinants of enteric fever. We'll look at the microbiology behind it, a brief shot at the pathogenesis, then we'll look at the clinical features, how to make the diagnosis, then the treatment, and then we'll follow up with the prevention. So for our introduction, enteric fever, as we may know, is basically an acute multisystemic illness that is basically characterized by fever, headache, and gastrointestinal symptoms, so abdominal discomfort. This severe systemic illness has fever and abdominal pain. So these are, I would say, very important or key features in enteric fever. Basically, usually the enteric fever is usually talked alongside with typhoid fever. So some schools of thought believe that enteric fever is the same as typhoid fever. And some people also think that it's part of a syndrome of diseases that's caused by the Salmonella species. So basically, for the purpose of this presentation, we'll look at enteric fever as a cluster of typhoid fever and paratyphoid fever. So the typhoid fevers being caused by Salmonella enterica, the subtype typhi, and the paratyphoid fever being caused by the paratyphoid ABC and all that. So basically, that's just what we talked about. So we continue with the introduction. Basically, it's more common in children and in young adults than in older patients. And basically, it's also very common in very poor countries or impoverished countries, i.e. is less encountered in the developed world and more encountered in the developing world. So our part of the world, like sub-Saharan Africa, is enteric fever is endemic in most parts of sub-Saharan Africa. Basically, it's a human pathogen. That's the causal organism. That's the S. typhi or the Salmonella typhi. And it's been there for thousands of years, as we'll see in the coming history. Basically, it's the main natural host. Humans, we are the ones who basically host this bacteria. And it's basically is transmitted through contaminated food or water. So we'll look at a few things, because over the years, the centuries and the decades, they've had various presentations of typhoid fever or enteric fever, and it's been looked at as various different things. But when we put everything together, we have this cluster of events that we call a multisystemic illness, that is the enteric fever. So in the ancient times, the ancient Greek used to call it typhus, and that was basically a smoke or a cloud that was believed to cause disease or madness. As we go on to look at the clinical features, you would see that typhoid causes typhoid encephalopathy, and they may have neuropsychiatric complications. So they had that aspect and they thought it was madness. This is the picture of the Roman physician Antonius Musa, who he treated the emperor who had a typhoid fever with a cold bath, and he was basically healed for that, and that was his own treatment. And all this is prior to the antibiotic era. And then you have the person who actually made the first description of it, Thomas Willis. And then the person who proposed the name is also here, and the differences between the epidemic typhus and typhoid fever, all the people all throughout the centuries ago. then the person who actually made the bacillus, the typhoid bacillus, the gram-negative bacillus, that is Salmonella, the person who made the discovery is here. And for the test that has been done for over 100 years, the Weidel test, Georges Weidel, who first described the agglutination reaction and seropositivity. And then the common story of typhoid Mary, who is known to be one of the major carriers of a typhoid fever over a period, who was a cook that was responsible for spreading a lot of the typhoid. Various accounts give different numbers of what she did, but this account says she gave rise to more than 1,300 cases in her lifetime. So looking at the endemicity of typhoid, you can see that in our part of the world, we told you that most of the sub-Saharan Africa, so everywhere in red that you can see on the world map, is basically typhoid has high endemicity in this part of the world. So you can see that Ghana falls into this category because we are in here in Africa here. So Ghana enteric fever is endemic in our part of the world. So it's important for us to know about it and how to approach a condition with it or a case with it. So we'll look at the etiological determinant. Now, Salmonella typhi is the major cause of enteric fever. It's not the only cause of enteric fever, but the one that has been mostly implicated in the enteric fever patients or the enteric fever diagnosis has been Salmonella typhi. So you have Salmonella paratyphi A, Salmonella paratyphi B, and even C. For some of them, they are more common in other parts like Asia and all those things. Those are the places that they are more common in. Now, you look at the typhoid fever and it's being caused by a bacilli. Now that is a rod, that's actually a rod. So what we are looking at is that it has three main antigens, the O, the H, and the VI. And this is important when we are looking at two things in the investigations and in the prevention with the vaccination. So it survives basically intracellularly, and then it's readily killed by drying, pasteurization, and common disinfectants. The factors that influence the onset of enteric fever in man are basically the infecting dose and or the amount of enteric fever that is ingested or the amount of the Salmonella typhi or paratyphi that's ingested and the virulence of the organism. So reservoir of the infection, as we said before, humans are the main pathogen for this. And we are known to be the reservoir in two ways. One, as cases, two, as carriers. So basically, who is a case? A case is a patient that is infected, someone who has the bacilli or the causal organism in their stool or in their urine. So the person is infectious as long as the person is has that infection or has that the bacilli in their stool or in the urine. And then the carriers, basically, there may be temporary carriers or they may be chronic carriers. So with the temporary carriers, they have the bacilli in their stool or urine for a period of about 6 to 8 weeks. But for a maximum of 3 months, this patient, by 3 months' time, the convalescent carriers, that's those who are recovering from the illness, they tend to have cleared the bacilli completely from their system. But for people who excrete the bacilli for more than 12 months after the clinical attack, that means after the onset of, or after the illness, or after the exposure, or after the acute phase, if someone still has the bacilli in their stool, in their urine, but more commonly in their stool, for more than 12 months after, then the person is known to be a chronic carrier. So this is just what we talked about. We talked about chronic Salmonella carrier, defined as excretion of the organism in stool or urine more than 12 months after the acute infection. So basically, research has shown that about 1 to 6% of people who get infected with Salmonella typhi proceed to become chronic carriers. So this is known, these rates are known to be increased in some specific groups of people. For example, women, they are known to be more women carriers than male carriers. And then it's also known that those who have cholelithiasis or biliary tract abnormalities, or anything that would cause a biliary tract obstruction in any way, will predispose the person to have predispose the person to become a chronic carrier. And we'll look at why when we are looking at the pathogenesis. So usually it's rare in urine. It's possible in urine, but it's rare in urine. And when the patient has persistent the bacilli in the urine, you have to also look at other urinary tract abnormalities like prostatic enlargement and urolithiasis. So basically, in a chronic carrier can excrete for more than for several years, so maybe as long as 50 years. And as long as the person is a chronic carrier, the reason why that's important is that the person is still infectious at that stage. So it's something that he can spread the disease, or he can spread the disease even if he himself or she herself remains asymptomatic. So the source of infection. So as we said before, the primary sources of infection are feces and urine of cases or carriers. So we talked about the cases and we talked about carriers. Basically, we know that the transmission of enteric fever is more often than not fecal-oral. But then from the urine to the oral is also a possibility, but it's more often than not fecal-oral. Now, the secondary sources that we have are contaminated food, contaminated water, contaminated hands. This is important when we'll be looking at the prevention. So what are some of the host factors that we are looking at? Age. Staying relevant to age. Typhoid fever is possible to occur in any age. And males are more affected than females. And then all ages are susceptible to infection. And then the host factors that basically contribute to the resistance that we will see will be the local intestinal immunity and the gastric acidity. So it's very important to note this. So the environmental and social factors that we want to look at in terms of this is looking at the environment, like vegetables grown on sewage farmlands, and then anything that would predispose your exposure to contaminated food or water. And then it's important to know that it grows, or the bacilli grows almost unrestricted on milk. That is, and it doesn't affect the taste or appearance in any way. And such ingestion increases the risk of the patient getting the infection. So all these factors are compounded by social factors like drinking polluted water, open defecation, low standard of food and personal hygiene. So basically, the increased rate of enteric fever in our setting is an index of the general sanitation of the public. So what's the incubation period of enteric fever? Different people have different ideas about this. Some say 7 to 14 days, but it's widely known that the incubation period is 5 to 21 days, the incubation period of the Salmonella species. But it can be as short as 3 days or as long as 3 weeks, depending on the amount of the bacilli that's ingested. As we said, the mode of transmission is the fecal-oral or the urine-oral route. And it may take place directly, that's we talked about the primary sources, and then also indirectly when that route is being passed on to other parts of the body, like the hands or like the food and the water, and also through house flies. So briefly about the microbiology. As we said, the organism responsible for the enteric fever syndrome, that's the typhoid fever and the paratyphoid fever is Salmonella, majorly is Salmonella enterica, the serotype typhi. But we have other ones that may cause a similar clinical syndrome. So the typhoid fever and the paratyphoid fever are similar clinically, and they are almost indistinguishable. Some people believe that a paratyphoid fever is less severe than typhoid fever, but clinically it's not distinguishable unless you isolate the particular organism for you to be able to tell that, okay, this is a typhoid fever and this is a paratyphoid fever, but everything is part of enteric fever syndrome. So Salmonella paratyphi A, B, C are the ones that can cause the other types of enteric fever. Also, there are also other ones that are not captured here. So briefly, we just want to go through this. We talked about the fact that the local immunity or the immunity to that the body or the host immune response to the salmonella, so salmonella ingestion basically is from gastric acidity and local intestinal immunity. So we'll know that most of the bacteria, when the body wants to fight against the bacteria, or when the bacteria wants to invade the host immune response, what it does is basically one is evasion and two is destruction. Some bacteria do one and some do both. So basically, when the bacteria encounters your immune response, it either tries to evade it or it tries to destroy it. Either way, it wants to proliferate and colonize your system. So basically, the first line of defense is that when the we said it's fecal-oral. So when the salmonella is ingested into the system, it gets to the stomach where, because of the gastric secretions, the pH there is low, so it's acidic, which is a harsh condition for the bacteria, but it's able to resist that condition because it can survive as low pH as 1.5. So from the ingestion, it goes to the stomach, and then that's where the pH plays a role. So it's able to survive this, and then it proceeds to go to the small intestine, to the duodenum, and subsequently to the ileum. So basically over there, what it's the things that we can look at from this will be that for after the stomach gets into the small intestine, we know that it tends to target Peyer's patches, and these Peyer's patches are intestinal lymphoid tissues. What is important is that it tends to overload the Peyer's patches, and then when it does that, that's the salmonella. I mean, when it does that, it leads to necrosis of that area of the intestines. Proceeds from necrosis of that area of the intestines to ulceration, and from ulceration, it may lead to perforation, and that's where the typhoid intestinal perforation comes from. Now, the other bacterially mediated endocytosis. So this, in simple terms, is the activation of macrophages. So macrophages, what they want to do is engulf the enemy tissue, so phagocytosis. So the macrophages tend to phagocytose this salmonella, but that's actually a good thing in some settings for the salmonella, because the salmonella uses the macrophages that engulf them as a transport system. So basically, what does it do? It's able to move through or navigate through the intestine because the macrophages have taken or have swallowed them, basically, so that they phagocytose them. Now, other things that you will look at in terms of evasion of the immune recognition or evasion of the immune system would be that we talked about the fact that the Salmonella typhi has 3 antigens, the capsular antigens. So it has antigen O, antigen H, and antigen VI. Now, the VI antigen is important because it's able to prevent the recognition of the, the bacteria, basically. So that explains for the fact that Salmonella typhi has greater infectivity than the Salmonella paratyphi. So that might explain why the Salmonella, people believe that the Salmonella typhi is more, um, it's actually more infective than the Salmonella paratyphi because of this VI antigen that it has. So it's able to evade the immune responses, so like the toll-like receptors and all the other immune surveillance. So that's what it does. And as I said, it uses the macrophage as a vehicle. So when it's taken through the intestinal tract and then sent to the mesenteric lymph nodes. And from the mesenteric lymph nodes, it's sent to the reticular endothelial system, so the thoracic duct, the lymph nodes, as I said, the reticular endothelial system, so the spleen, the bone marrow, the liver, and from there, spread. So what it does is part of it, some of it tends to spread to the bloodstream. After what it actually does is it pauses and it loads that area until it blows open and then it spreads to the bloodstream through hematogenous spread. And then from the reticular endothelial system and also from the lymph nodes, it seeps into the bladder, the gallbladder, and is stored in the gallbladder. So it's important why you see that with the chronic carriage that we talked about, they tend to, in people with a biliary tract obstruction and chronic cholelithiasis, tend to be more of chronic carriers than this because this is stored more in the gallbladder, and it's from the gallbladder that is excreted in the stool and the urine where it can be detected for treatment. So that's basically what we are looking at. So this is just the notes to look at all that. So basically gets to the pair patches and then it moves through evading all the immune responses. So this is just a summary of it. So that when there's ingestion of contaminated food or water, it invades into the small intestine, seeps into the bloodstream, carried by the macrophages into the reticular endothelial system, and then they multiply and re-enter the bloodstream. The bacteria invade the gallbladder, the biliary system, and the lymphatic tissue of the bowel, and they multiply in high numbers, and then they are passed into the intestinal tract and get into stool and urine as well. So for the clinical features of this, what are we looking at? Basically, as we said before, the multisystemic illness is looking at fever and the GI symptoms. Just looking at the pathogenesis, you would see why most of it is the GI symptoms. But then with the complications, as soon as the bacteria gets into the bloodstream, it can feed to a lot of other places. So of course, it can affect many other places. So we'll look at it based on how it presents, how it will present first. And depending on the time you as the clinician will catch the infection. So basically, we are in an endemic region. So in a patient that comes to you with fever, that is usually a stepwise ladder pattern, a stepwise ladder pattern of fever, and gastrointestinal symptoms should pique your suspicion for an enteric fever. Now, it's also possible for it to come with low-grade fever and then also with diarrhea. So some schools of thought initially, what used to be the case was that because of the loading of the bacteria in the intestinal tract and then the invasion of the pia patches, constipation used to be seen to be more or in more cases over time. But recent research has seen that constipation and diarrhea occur at similar frequencies. So we're looking at constipation, you're looking at diarrhea, you're looking at abdominal pain, you're looking at the fever, which is the specific pattern of fever. And then, as it says here, the untreated typhoid fever may go on to obtundation, delirium, intestinal hemorrhage, bowel perforation. These are some of the complications. Now, We said it's the clinical syndromes, you cannot distinguish them. So you don't know whether it's from Salmonella typhi or paratyphi. So it's very difficult to distinguish clinically. But the fever pattern that we see is step ladder wise. So it basically goes up and then in the morning it comes down again. It goes up in the morning, it comes down. But what you see is that practically is that the peaks and the troughs of the fever are increasing steadily every time. So it's not like it goes down completely to normal. It comes down from where it was in the morning, but it's still higher than the previous day. Now, another thing you tend to see in the first week of the illness is the abdominal pain. So the abdominal pain, basically the abdomen will be tense, and then the abdomen will be tender, and there may be right hypochondriac pain or right upper quadrant pain that you would see. So we talked about the fact that monocytic infiltration inflames the bile patches, and there's narrowing of the bowel lumen that will lead to the constipation that lasts basically during the duration of the illness. Now, an individual that develops a dry cough, dull frontal headache, delirium, and increasingly stuporous malaise, so the patient is just slow. That's what you will notice. But then at the end of the first week of the illness, you will notice that the fever has plateaued or the temperature has plateaued. And usually you see them getting high temperatures. Not always, but usually around 39 to 40 degrees Celsius thereabout. Now, clinically, another thing that you would notice getting between the first week into the second week is the development of rose spots. So what you see about them is that it's not very easy to distinguish in dark skins, but you look at, they said you see salmon colored, or basically they are reddish and they are blanching and basically they are macules, but they may be papular as well. Usually just about this wide and very few, and they resolve in a very short time. Now, during the second week of the illness, some of the things that you might tend to see is that, as we said during the abdominal assessment, the abdomen is distended and there may be splenomegaly. Now, this is important because the patient may have relative bradycardia in the presence of the high fever, the Faggot sign. And then there's also dicrotic pulse, or there may be dicrotic pulse if you assess the pulse. That's a double beat, but the first one is stronger than the second one. Now, in the third week, what you notice is that the individual starts to lose weight in the third week. He's still febrile, but he starts to lose weight. There may be injected conjunctiva. The patient may be in distress, and then difficulty in breathing with a treaded pulse, and there may be crepitations over the lung basis. Abdominal distension, it keeps worsening, and some patients may now develop this that is called a pea soup diarrhea. Now, when you are getting towards the end of the third week to the fourth week, you start looking at neuropsychiatric complications. So as we saw initially they used to think that typhoid causes madness, and there is a setting in which typhoid may lead to altered mental status or loss of or reduced consciousness level. That's the typhoid encephalopathy. So we see that it may be characterized by apathy, confusion, there may be even psychosis. The pair patches, which we said that they proceeded from obstruction of the lumen to necrosis. The necrosis, it may become ulcerated, and from the ulceration, it may then perforate. And then when it perforates, the patient may have clinical signs of peritonism. So that's what may happen. That's another complication that's possible. But then in the fourth week, then the patient basically starts to come around. So it starts to improve the clinical condition. The intestinal and neurologic complications would still persist, but then they're improving slowly. But then the weight loss, the things that last for very long will be the weakness, the weight loss, and then the neuropsychiatric complications might last for months before the patient is fully recovered from the typhoid fever. But it's important to note that you may not see all these you may not see all these clinical features in one particular patient or in every patient. So they will present basically differently. So for the diagnosis of the enteric fever, what are we looking at? We are an endemic region for typhoid. So is what we want to do is that we want to take a very good history and a thorough physical examination in view of what we looked at in the previous slides. So you look at the patient and then you want to assess all the other things that we looked at in the clinical features. And then your index of suspicion should be high in a region like us. Now, what will be some of the things that will be considered diagnostic? The mainstay for the diagnosis of typhoid fever by way of investigations has been culture of the specific isolate or culture of the specific causal organism. So what we want to do, we know that culture is 100% specific, but then the sensitivities vary. And then what are you culturing? So depending on what you are culturing. Now, you see here, we started with bone marrow aspirate, which it has the highest sensitivity in a diagnosis of enteric fever. It has about 90% sensitivity. The blood, which you would need to do serial blood cultures, you have to do it at least 3 times or more, has a sensitivity of about 73 or so percent, which also helps in the diagnosis, but it's been known to be more effective in the first week of the illness. So depending on when the onset of symptoms and then what you are going to request, what is likely going to isolate the organism. Now, the stool culture as well is important and is useful in the later parts of the condition. The urine culture is not as sensitive as the blood or the stool culture, but may still isolate the organism. Other things that you can do are a rectal swab. The rose spots can be cultured. The duodenal secretions can be cultured. And then the cerebrospinal fluid as well can be a cerebrospinal fluid, if it's possible, can be cultured. Peritoneal fluid, mesenteric lymph nodes, the resected intestines, pharynx, tonsils, all these things can be affected by the salmonella, so they may be cultured. So as we said, 90% sensitive, at least until after 5 days of the commencement of antibiotics, but it's not routinely done in clinical practice to culture the bone marrow just for enteric fever. Now, so we talked about all this and there are various sensitivities, because we know that it's 100% specific. If it gets it, you need large volumes of the blood and you need multiple blood cultures. So we said 3 or more, about 73 to 97%. It increases the likelihood of detection. And then the stool culture has a sensitivity of less than 50%, and urine is even less. So the supportive tests, what are you looking at? You are looking at serology. In addition to, we'll talk about the other supportive tests. So when you talk about serology for this, we want to look at antibody identification. So basically, it's the vital test that we do. So you want to get the salmonella antibodies or antigens to support the diagnosis of the typhoid fever. So it's not a diagnostic test for typhoid fever. It's a supportive test if you will do it. Now, in the earlier years of the typhoid, vital test was the mainstay of the diagnosis of enteric fever. And basically what it does is that we told you that the Salmonella typhi has H and O and VI antigens. the VI capsule antigen. So what it does is that it measures the agglutination antibodies. Now, it's not very specific, and it's also not sensitive as well. So it's been recommended that it's not an acceptable clinical method to assess a patient with enteric fever. If you have your clinical history and you're not able to do cultures, you don't need an enteric, you don't need a vital test to decide whether you treat or not. So these are some of the other these things you can look at: indirect hemagglutination, indirect fluorescent VI antibody, and then the ELISA as well. You can also look for the IgM, which tells you about either a current or an ongoing or a very recent infection, or the IgG antibodies, which will tell you about a chronic infection or something that has been there for a long time. Now, what will be some of the limitations to the vital test? So we said that serological tests, especially the vital test, have limited clinical utility. So we really don't need to do them in endemic areas like Ghana, because the positive results represent, as we said, a previous infection. And then there is often also cross-infection with, or cross-reaction, I should say, with some of the other conditions. So other conditions can increase the vital test. But even if you would do it, you have to look at the paired and the convalescent sample. So within the course of the illness, you test the first vital test and get a baseline for your agglutination of the antibodies. And you need a fourfold rise of the titers or more to be considered seropositive. And that's just what supports the diagnosis of the enteric fever. It's not even diagnostic. Now, the specificity has been shown, as we said, to be very low. So the low specificity, low positive predictive value, but it has a high negative predictive value. Now, the vital test can also be false positive in patients who have had vaccination with or a recent infection with Salmonella typhi, because you are checking the antibody. Any previous exposure will shoot the values up. Now, what will be some of the other tests you can do? So you can do the full blood count, where you look, the patient may be anemic, the patient may have thrombocytopenia, and there may be lymphopenia. The ESR will be raised, the CRP will be raised, the urinary, and then the RDT or blood film for malaria parasites, also to rule out other conditions that may mimic this particular condition. Now, the renal function tests, the patient may have hyponatremia or hypokalemia in the setting of the enteric fever. Now, the liver function test is usually very deranged, so there's usually a mixed picture, and you may have decreased synthetic function, decreased hepatic function, and also there may be impaired, I should say, impaired cholestatic function. So what are we looking at? The transaminases are high and the bilirubin levels are high. And then there is a caveat. There's usually an ALT to LDH ratio. So if it's possible for you to do an LDH ratio. So there is typhoid hepatitis as well as the acute viral hepatitis. So there's a ratio. If the ratio is more than 9:1, the ALT to the LDH ratio, it supports the diagnosis of acute viral hepatitis. And if the ratio is less than 9:1, it supports typhoid hepatitis. So it will be important to do chest and abdominal radiographs to look for evidence of typhoid ileal perforation. Now, what will be some of the differential diagnoses? So in our setting, malaria, we'll look at amoebic liver diseases, hepatic abscesses, we look at appendicitis, and then abdominal abscesses, abdominal tuberculosis as well will also be things you want to look for, and some of the other diagnoses are also there. Now, with regards to the treatment, what are we looking at? We have treatment goals. Now, the treatment goals are to eradicate the infection, one. Secondly, to detect and manage complications of the condition. And three is to prevent transmission of infection to other people. So these are three things we want to do. Now, enteric fever, basically, by way of treatment, it's important to do a single antibacterial, antimicrobial agent. So what are we looking at? You want to know in our setting, we have what is selected for us in Ghana. There are very, very different settings depending on where you are. For example, there are places that have XDR, that's they have multi-drug resistant typhoid fever. Some people also have extended drug resistant typhoid fever. For example, just within our part of the world, in Nigeria, what their first line will not be the same as our first line because enteric fever is hyper-endemic in Nigeria. In places like Pakistan and all those places, they have hyper-endemic. So the strains of the enteric fever that they have and the resistance of the enteric fever that they have will not be the same as what we have. So it depends on where you are. But if you're in Ghana, we'll talk about what you use. So basically, the main options that we are looking at are the fluoroquinolones. So like the ciprofloxacin, the ofloxacin, those are the main options, and that's the first line. Now, the third generation cephalosporins are also used and important, and then azithromycin. But when you get the condition that, when you get conditions that are, I should say, you get conditions that are resistant, or they are resistant to our first line, it's important to know that the carbapenems are also used in extensively drug-resistant strains. So like the meropenem and those ones can be used. We are moving away from using the older agents such as chloramphenicol, ampicillin, and the cotrimazole. So when do we give oral therapy? When do we give parenteral therapy? So in uncomplicated disease with no evidence of systemic toxicity, patients can tolerate oral therapy. You give oral therapy. If there's evidence of systemic disease, as we talked about in the clinical features, then you give the parenteral agent. Now, there's a place for in very severe systemic illness, the use of adjunctive dexamethasone for 48 hours as part of the treatment options. So in Ghana, what's our first line? First line is ciprofloxacin as we oral if it's in very severe, in uncomplicated conditions, and intravenous ciprofloxacin for severe conditions. But if this is not working, your second line is for severe, is IV ceftriaxone with the time as we say, and then oral azithromycin with the time as we say. So what's the next thing? The next thing is follow-up. Now, this is something that in our part of the world is not very common. It's not something that we usually do, but it's important for you to look at the patient or follow up on the patient that's being managed for enteric fever. Usually within 3 to 5 days in the onset of, and I might add, the invent of, or the advent of antimicrobial therapy has made enteric fever much less of an issue than it used to be. So the mortality rates prior to the advent of antibiotics or the use of antibiotics in the management of enteric fever was high, more than 15%. Some sources say 20 to 30%. But now the mortality rate that we have all over the world is less than 1% from enteric fever because of the advent of antimicrobial therapy. So it's important. So in your management, once you get the clinical picture, it supports it. you start the treatment pending the cultures that you are doing. So you don't wait for cultures. You start based on your region, as we said. So ciprofloxacin is our first line, except you have evidence or suspicion of drug resistant typhoid. So we said you can start seeing improvement, or the patient can get better within, or clinical improvement within 3 to 5 days. So most of the trials that were done, the mean time of defervescence, that means the patient's fever to be controlled, is for about 4 to 6 days. So if you see that the patient's fever is not getting controlled after 3 days of you starting the therapy, it doesn't necessarily mean that there's treatment failure. So it's important to know that it takes about 4 to 6 days. But if after this period, then it's not working, so maybe after about a week, the temperature is not settling, then you are looking at something along the lines of therapeutic failure. Now, relapse, this one is possible. That means that a patient had acute infection, recovered from acute infection, and went back. So basically, it occurs typically in patients about 2 to 3 weeks after the resolution of the fever. So after the effervescence, the patient can go back and get a relapse. So basically, in our setting, relapse should be treated with an additional course of antibiotics. Basically, if you have done a culture and isolated something, and you've done your culture and your sensitivity testing, the same antibiotics that was cultured can be used for it, but it's just that a longer treatment course. So basically, you can give them for maybe up to 3 to 4 weeks of the antibiotics. And the third generation cephalosporin has been put forward, especially ceftriaxone. Now, we talked about chronic carriage of Salmonella. So what did we say about it? We said when the patient is has the acute infection for more than 12 months, then it's a chronic carrier. We talked about the convalescent carriers. Those ones usually by 6 to 8 weeks, or at most for 3 months. But when the patient has it for more than 12 months, you look at them and you say they are chronic carriers. And these people are public health hazards. So it's important for us to look at these people, but routinely, we don't do the post-illness screening for them to know who is a carrier and who is not a carrier. And we talked about the fact that about 1 to 6% of the patients who have been diagnosed of enteric fever tend to be chronic carriers, and it's more common in women and those who have biliary tract issues. So there's a place for eradication of the carriers, because once such a person is identified, and usually they are not commonly identified, they are only identified in a public health screening. So maybe some campaigns go and screen people who sell food, and then all those things. Those people can be picked up, and when they are picked up, their eradication has to be done. What we do is that we do a long course, and the fluoroquinolones have been shown to be successful with the treatment of chronic carriage. So we do a long course of fluoroquinolones, like for about 4 weeks, and you may or may not do cholecystectomy, but it's important. It's part of the treatment options for them. Now, for the prevention, what are we looking at? We are looking at we said it's fecal oral. So we want to get our food and water to be safe. So hygiene, hand washing, and all those things, because basically and especially with the food, because it's been known that the inoculum is higher in the food than in contaminated water. Now, concerning vaccination, there are vaccines available for enteric fever. Now, there are recommendations for endemic regions like us, and then for the non-endemic areas. So basically for us, it recommends there's a typhoid conjugate vaccine. And these ones are for people in the endemic regions like Ghana for the efficacy, because it's been shown to be very effective. One, it's also shown to be very safe in infants and young children. And then but it looks like in Ghana, it's still in the preparation phase or the pilot phase. In non-endemic areas, typhoid vaccination, that one is not part of their normal vaccination. It's basically for those who are going to travel or for travelers to endemic areas. So those ones can be vaccinated. So the vaccinations, we talked about the typhoid conjugate vaccine. That one is given as a single IM dose. And then the polysaccharide vaccine, which is with this one also looks at it uses the VI capsular antigen. And then that one, when you give the single IM dose, if you need extra protection, maybe you are going to a region which is hyper-endemic, you need to take every 2 or 3 years a booster dose. And then the TY21 vaccine, these ones are, the first two are killed vaccines, but the TY21 vaccine is a live attenuated vaccine. And that one, you take it, it's taken for 3 to 4 doses on alternate days. So day 1, day 3, day 5, day 7. Basically, none of the vaccines have been completely effective against Salmonella typhi. And none of them have also been used against paratyphi. It works against typhi. You can see that the VI capsular antigen that is on just the S typhi, that's what it attacks. But the vaccination has not been used or proposed for the paratyphoid fevers. So what are some of the complications? So this one will give you a picture. Orodental like parotitis, and then basically spread of infection along the body, bronchitis, pneumonia in the second week, myocarditis, hepatitis. We talked about the typhoid hepatitis. For the GI, commonly intestinal hemorrhage, intestinal perforations, and peritonitis, encephalitis, meningitis, encephalopathy, the typhoid encephalopathy. Then the other features that we talked about. So in summary, what are we looking at? Enteric fever is an invasive bacterial infection acquired through the consumption of contaminated food or water. The organisms, as we said, that are responsible for it are typhi, Salmonella, Enterica, the typhi serotype, and the paratyphi. A, B, C are the common ones, but there are others. Because the incubation period is about 5 to 21 days, and it causes fever, chills, and the abdominal symptoms, abdominal issues. It's endemic in Ghana, hence it's important for us to use our clinical suspicion. So if you see a patient with step-ladder rise pattern of fever and GI symptoms, it's important to suspect in our setting. The vital test is of little clinical significance. And in our setting, most diagnosis of enteric fever is made presumptively. So it's important to initiate early antibiotic treatment. So these are the references. Thank you.
Excellently done, Dr. Excellent. We thank you for the brilliant presentation. Like I saw some of the comments from this. So we zoom in straight to the various comments and questions that were put in the Q&A. And then if we still have some time, then we allow for people to ask some questions. Just before we go through the Q&A, there are a couple of so many participants that we have had. We are honored to have Dr. Odalis, the head of Department of Medicine of the Tamale Teaching Hospital, my very own sweet boss. We thank you for joining us. And if you do want to make a contribution, you could electronically raise up your hand and then we would. We're also joined by a lot of the pediatricians. I see Dr. Haruna, Dr. Matilda from the regional hospital, as well as a lot of the pediatricians. Also saw my gastroenterology fellow, Dr. Enine J, as well. I'm sure he'll have a lot of insights about enteric fever, as well as so many other colleagues who have joined in, our very own Dr. Ato, Dr. Tinka, and so many others. You are very much welcome. To make this presentation rich, usually we would say that if you do have insights into these, you could do share them in the chat box, as well as put up your hand, and then we can give you the opportunity to have your comments shared. So I'll quickly go through the various comments in the chat box. Dr. Excellent, so those that are questions, you see if you can address, and then we take it out from there. The first one was from Dr. Joel Agorinya, one of our very regular participants, and he always brings the insight of mental health into most of our conditions, which is extremely important and makes the discussions rich. So he did send me this, that you could remind them about the diagnosis of typhoid psychosis, which some clinicians sometimes make in the settings of a psychotic disorder, simply because the WIDAL was significant, and his significant is in quotes. Obviously, I'm sure Dr. Excellent has done justice to the WIDAL. I don't need to say more. And so they end up overdosing them with unnecessary antibiotics. So we thank Dr. Joel for the great contribution, and I'm sure it's opened our eyes to the fact that typhoid psychosis is real, but of course, you need to make it in the setting of where you think clinically it is typhoid, rather than just a WIDAL test, especially in an endemic region like ours. And the next one was from Sani. He says, thanks, doctor, for the wonderful presentation. About the investigations for enteric fever, I've realized that in this part of the country and the peripherals, where a lot of facilities don't have access to labs equipped to do culture and bone marrow aspirate, and we rely so much on WIDAL tests, can't we encourage for a community endemic average range value for WIDAL test, or we should just base on clinical judgment? Dr. Excellent, what's your comment on that?
I think he has just answered it. So please, as we said for the summary, many of the diagnoses of the enteric fever we'll make in our setting is presumptive. So you base on your clinical suspicion and treat, because it will not help you either way, except you even want to do it the right way. And even if you try to use the vital test to demonstrate the fourfold or more rise in titers, it's still just supportive. So if your clinical suspicion is high for enteric fever, then you treat. There are some of the other things that we can do. I understand the issues with the local setting, but some of the other things that can be done is at least an RDT or a malaria test to rule out some of the common differential diagnosis for the for enteric fever. But if you have a high clinical suspicion, it's important to treat. And if you are in a setting where cultures can be done, please go ahead.
Great. We can't overemphasize the need for you to use the clinical judgment, more so in an endemic country. Like you would have seen Dr. Excellent did mention, the WIDAL or VIDAL test, depending the pronunciation, depending on where you are coming from, is good for its negative predictive value. And as such, it will be more useful in settings where typhoid is not endemic, because obviously where it is endemic, you almost always have titers that are higher. And so you won't be able to say that this is typhoid just because of the fact that the titers are higher, rather than demonstrating a fourfold rise in titers. Where it is not endemic, where you don't have so many people with typhoid, then it's likely that, of course, when you do it and it is up, probably the person may have been exposed acutely or maybe a chronic carrier or whatever. But of course, in our endemic region, it will only be good if the titers, you do it and then it's normal. The WIDAL is normal. Then, of course, you're able to exclude typhoid, sort of. But the emphasis is on your clinical judgment. I move on to Dr. Atinka. I think he asked a question. Does the Upper West Regional Hospital Laboratory have the specific culture medium for isolating the Salmonella typhi and para-typhi. I saw Mark, who is the lab head, up. I don't know if Mark does want to respond to that.
Yeah, thank you, Dr. We have the social medium, and we've been receiving such requests from our clinicians from time to time.
Great. Thank you very much. Our biomedical scientist. So that's available, Dr. Atinka. So of course, if you request, it means that it can be done. Thank you, Head of Lab. His second question was, just a minute. Second question was about wonderful presentation, Dr. Excellent. Is there an effect of antibiotic usage on the duration of bacterial excretion in feces? And if so, can you explain any further? Dr. Excellent, do you have an answer to that?
Okay, so basically, yes, there is an effect of the antibiotic usage on the bacterial excretion in the feces. So what we know, we're talking about the patients, and we're talking about the patients as in terms of excretion of this thing, talked about carriers and the convalescent carriers. So either way, whether you use the antibiotics or not, it's going to be cleared in the feces. But even when you are treating patients with as chronic carriers, you still treat them with the antibiotics. So it reduces the concentration of, it reduces the amount of the bacilli in the feces, one. And also for the duration, the more, if you treat with the antibiotics for the required period, there's less amount of time that the patient can be a carrier, except of course, the patient has other factors that would predispose the person to be a carrier for a long period of time. If I get what you're saying, that's the idea I have, because the antibiotics will help to clear the bacilli completely. But if the patient is already going to be predisposed to be a carrier, then the antibiotics may not help in that setting. So it's going to be there for as long anyway. And it's been noticed that just about the 1 to 6% of people have been carriers for that period of time.
Yeah, great. So I guess he's looking at usually the prolonged excretion of Salmonella following the antimicrobial therapy. I think those have been actually documented. And the reasons they usually give is possibly because of the fact that, like Dr. Excellent rightly said, the Salmonella typhi, they are usually intracellular. And so they are protected from the action of the antibiotics. And so sort of they still, usually people would have fecal excretion despite the fact that they are on antimicrobial therapy. But of course, we are not looking towards making the gut a sterile place for organisms. What we are looking at is the systemic effect of the Salmonella typhi. This holds more usually with regards to salmonellosis and all of that. I hope that does address your question as well. The next one, I think, is from Dr. Issa. He says a great presentation. No, just before then, sorry. Fatah says that, is it safe to put a child on the ciprofloxacin for 14 days since it has a risk of tendinitis in them, especially when used on the long term? I think we'll let one of the pediatricians take a go at this. Back in the days, there used to be no ciprofloxacin syrup, but now they do even make syrups. And I hear the issue about tendinitis has been overestimated. And I don't know, let's get an expert to do that. Dr. Matilda, could you kindly help us? If you could unmute yourself and then go ahead. Dr. Matilda is the pediatrician at the Upper West Regional Hospital.
Hello, good afternoon.
Good afternoon, boss.
Lost my voice.
Sorry.
But just to contribute to the discussion, yes, in the past, it was totally not accepted. You could not use Cipro to treat children. Now, that many studies have come to show that it's actually a limited, it's quite limited, as in a number of children have been noticed to suffer the atherotoxicity that we're afraid about. So we currently use it in the treatment. So we always encourage that you do a benefit versus risk assessment and go ahead and use it. So currently we use it actually. Mahama has anything to add, he can add. Thank you.
All right, great. Thank you very much, Dr. Matilda. Dr. Mahama, if you have anything to add, feel free to unmute yourself and then do the same. So the Upper West is quite rich. We have four pediatricians, 3 of them coming in this year to join Dr. Anastasia. So I'm sure they will build a pediatric faculty in the Upper West. Great. So the next question, from Dr. Issa, great presentation. Is there an average duration from the onset of acute infection to the development of complications, the typhoid ileal perforation to be specific? That's his first question. Dr. Excellent, is there a duration?
Yeah, so it's, as he said, average duration. So when we're talking about the slide, around the 3rd week is mostly when the TIPs tend to develop, when the pile patches get necrosed and then the ulceration occurs and the perforation tends to occur. It occurs around from the end of the 2nd week, between the end of the 2nd week to the end of the 3rd week. That's when we get that particular complication happening.
Great. So his next question was, are there specific factors that can hasten the development of these complications?
Yes. So just as we said, just being in an endemic, we talked about the fact that the condition is for impoverished and then developing and poor countries. So the nutrition status and then the immunocompetence are factors to consider, that if those things are there, they will tend to, or immunocompromised, I should say, they will tend to predispose the patient to have more of the complications. Then other things that we can look at will also be the resistance patterns. What are you using to treat the patient? And is the patient susceptible, or is the Salmonella susceptible to that, your therapy, or is resistant to the therapy? So those things can all predispose the patient to having complications relatively quicker.
Great. His next one, so I think that's it with Dr. Issa. Then Sani asks, the first-line treatment for enteric fever, as he said, is ciprofloxacin. So in children and pregnant women, will you still consider it? I think Dr. Matilda did address the issue of children, so that's answered. How about the pregnant women, Dr. Excellent?
Okay, so with the pregnant women, we don't give ciprofloxacin as any line, not even first line or anything. We don't give them ciprofloxacin. We use other antibiotics. Some people give second generation cephalosporins like cefuroxime, which has been shown to be safe in, they have been shown to be relatively safe or have a safer profile in pregnancy. So that's what is given basically. That's what people do. That's what some researchers decide to do. They don't give ciprofloxacin in enteric fever.
Great.
In pregnancy.
Great. Yeah, so that answers it. Also, there are usually other options like the 3rd generations as well, and cefixime has been used as well, and even amoxicillin. and the Septrin as well. So those are options. But of course, there are usually local guidelines where medicine is best practiced. You have local guidelines, and even in that local guidelines, hospitals do have their guidelines. So it may not be prudent to throw about the antibiotics, but based on local antimicrobial resistant patterns. Great. Dr. Odalis did say, thank you for inviting me. I said she has to leave for another meeting, but great presentation. Then Mavis Mallory asks, in pediatric situations, Cipro safe. I think Dr. Matilda answered that. Then Dr. Matilda mentioned that you did a wonderful presentation. Dr. Haruna, please, doctor, do you have a vaccine in Ghana? I think Dr. Excellent did address that. Dr. Aboaji says, thanks for the presentation. Zionai says, great presentation. And Mr. Mark, the biomedical scientist, a little contribution. In as much as we want to isolate the organism and do antimicrobial sensitivity testing, it is most appropriate to delay initiation of antibiotics until a laboratory specimen is collected. Thank you. So great one there. So once we make the clinical suspicion, it will be good to take your samples and start the antibiotics. Take samples, start the antibiotics, and then we can go ahead. Lives are more precious, so it will be good to start the antibiotics as promptly as possible, but make sure you take your samples and let them ship that away. You don't have to wait for the result before start of antibiotics. You take the samples and start. Then Zionite says that, please, I would like to know if second generation cephalosporin like cefuroxime are adequate enough for treatment of typhoid fever. I think Dr. Excellent did just address that. That's it for the questions and comments in the chat box. We'll allow some 5 minutes for anyone who has a contribution. Otherwise, then we'll draw the curtains on this wonderful presentation that Dr. Excellent has done. So if you do have a contribution or a closing remark, kindly electronically put up your hand, and then I'll let you unmute yourself and go ahead. Okay, Dr. Neneje.
Okay, so thank you very much for such a presentation. I think this is very enlightening. I think one thing we have to take critical look at is how to differentiate acute fulminant hepatitis from enteric fever. I've seen a few situations where people have been flooded with antibiotics, for several weeks because there was suspicion of enteric fever.
I think we lost Dr. Please unmute yourself, boss.
Can you hear me now?
Yes, please. We can hear you.
So the point I was making is that usually the liver complications for enteric fever would start somewhere in the second week, and some literature actually suggests it's not complication; it's actually a part of the complex. If you have the situation where the transaminitis or the deranged liver function is actually starting immediately at presentation, you should rather think more of hepatitis B. And the Paget sign is one thing that also helps to differentiate the two. So you have high temperature but low pulse. I must quickly add that Paget sign is not almost always equal to enteric. There are several other conditions that will give you the temperature pulse mismatch. Tularemia, even yellow fever, legionellosis and all that stuff. So, the history, very, very important. It can't be overemphasized. And let's all try to, at least if the patient is jaundiced, rule out hepatitis B as part of your differentials. So thank you very much.
All right. Thank you very much, boss. And that was great. Dr. Felix is gastroenterology fellow. This our presentation is super rich because you are getting the experts in the various fields, and take our words for it. Of course, if you want an update, it's better you get it from the experts. I don't see any other hand up, as well as check in the chat box. Someone is asking, please, how do you get this presentation? I think I put up the number, just send hi. And then once the video, the Zoom recording is available, I'm happy to share it with you. I've shared it with you, James, and I've shared it with everyone again, regards the number. And then usually it takes about 24 hours or so, then the recording is made available, and then we can share it if you need that. Thank you very much. So we wish to thank Dr. Excellent for a great presentation, fantastic. Obviously, I've been educated and enlightened, more especially about the weed-out test and the fact that there are things that we should probably do rather than waste people's time and money on tests that may not add in or subtract that much. And more importantly, not to keep treating people who go and come with a weed-out of 160, 1/160, 1/320, and they just, I've ever attended to a case, I think about 2 months ago, where the man has been on ciprofloxacin and switched to ceftriaxone and all of that, simply because the weed-out just keeps coming in about 160, 1/160, 1/320, and so they just kept treating him as such. All right, so we wish to thank all our participants as well for joining us in this presentation. We are glad to have had you. We will take a Christmas break from these presentations and resume next year, as we usually see on the various platforms. We'll advertise once we get in and about the second week of January. Till we meet again, take very good care of yourself, protect yourself, COVID is real, and have best wishes for the festive season ahead. Bye-bye.